This presentation concerns pain assessment, and by that I mean assessment of the pain, how to assess the patient, and the patient's assessment of their pain. Pain is a complex series of symptoms common to many different diseases. I'm going to talk about the tool Socrates to assess pain, and then talk about the different types of pain. But first of all, I want to talk about the patient with pain, and I'm going to finish up by talking in some way about the experience of pain. So the patient with pain is your best and sometimes your only witness to the pain. So they have all the information, or much of the information, that you want to get. They may not be as articulate as you, so don't prejudge how they express themselves, and do help them to try and express themselves fully. Remember, not all pain is the same. Some pain relates to an anatomic cause, other pain relates to a process, and that needs to be gleaned out from mainly your history taking. Communication needs to be good and two-way. You need to be accurate with regard to the questions you ask and the terms you need and use. You need to use unambiguous words and encourage the patient to clarify an inaccurate and imprecise language. And you need a skill and the right questions to do that sympathetically. Try to quantify what's going on and to record so that after an intervention you can compare what has happened to the pain and the pain experience. Accuracy starts off with knowing what the site of the pain is, and asking the patient to point rather than describe the site of pain is very important. Start off to get the right site with accuracy. Talk about radiation and the extent and all features about radiation. Then using good communication skills. So inaccurate or imprecise language like all over, always, needs to be clarified. So that by always, you need to say, does that mean all day, every day? And if the patient denies that's what they mean, then you need to clarify out how much they mean by always. Try to quantify. The use of numeric scales is very easy for the patient, and it allows you to compare one patient visit with the next. Your attitude is very important, and your attitude is communicated. So a sympathetic and understanding ear is very important. It's therapeutic, and you need to have an attitude that is communicated, one of understanding, of comprehension, and of empathy. So the patient has got a listener that is not too hurried and wants to get the full story. That helps productivity. If you've got all the information before you start your examination or your investigations, first of all, they'll be better targeted, and second of all, you won't be doing unnecessary things. So your time is saved by starting off asking the patient about pain with a good tool. The patient outcomes are far better when the patient is on your side, as it were, and feels that you are sympathetic and understanding of their problem. You need a protocol, you need a tool so that you know why you're asking what you're asking. You ask all of the questions that need to be asked, and you get all the answers, and then you get a complete picture of what's happening to the patient, and that of course instills confidence in the patient, the fact that you've got your full picture. So you need a plan, starting off with a tool that gets you all the answers, and then they're integrated into a hypothesis or a differential diagnosis that allows you to proceed with your further investigations, therapy, or management. And one such tool is Socrates. It's a mnemonic for many of the different aspects of pain, and using a mnemonic like this allows you to take comfort in having a full picture if you use it regularly. And of course, regular use of a tool improves your own use of the tool. Site, onset, character are features that you ask about from any pain, including radiation, associations, time course, exacerbating and relieving factors, and severity. So there are three types of pain, broadly speaking: nosioceptive, neuropathic, and generalized central pain. Now, pain is an unavoidable aspect of our existence. We all have experienced pain, and we all will experience pain, while suffering depends on our reaction to that pain. And that is an important thought in thinking about how you're going to alleviate a person's pain or pain problem. Now, not every pain is the same. So we'll take Mrs. Fellenzood and we'll go through her story. She's not a real patient, she's a conglomeration of patients. 53-year-old lady, fell in the supermarket, very painful wrist, unable to turn a key or to grip with her hand. So she goes to A&E. It's a possible fracture, so it's immobilized. Come back to the fracture clinic. She has nosioceptive pain. She's had a painful stimulus at the fall or the floor. It's of somatic origin, it's clear cut, and this can reflect a trauma or a disease or inflammation or some such lesion that is easy to identify, and that would be the common experience of pain, our common experiences of pain. But not every pain is like this. So Ms. Fellenzood has nosioceptive pain, whether she got a fracture or not. This is a nosioceptive pain and will benefit from immobilization, analgesia, and it should get better in an appropriate amount of time as healing proceeds. So she goes to the OPD and gets a plaster, and she's immobilized after having the fracture diagnosed, but she's got a lot of pain under the plaster, and this sometimes happens and goes on for 6 weeks, and there's repeated checks to see, is the plaster too tight? Is there a vascular problem going on? And no, it's okay, everything is all right. So at removal of the plaster, she has severe hand pain and is swollen. The hand is cold, there's allodynia, and the patient is holding the hand in a sort of a claw-like immobilized situation. She can't touch anything. So she's sent straight to physiotherapy and occupational therapy to mobilize the hand as a matter of urgency. So this lady now has a pain that is much more widespread than the original trauma pain. It's going on for a lot longer than one would expect, and so she's having appropriate urgent mobilization. So she probably has a neuropathic pain, and that can come from entrapment, peripheral nerve lesions, root pain, glove and stocking, or autonomic. So entrapment is our common experience of median nerve entrapment of the wrist, causing carpal tunnel syndrome with pinching of the median nerve at the flexor retinaculum. Often associated with paresthesia and numbness, and maybe preceded by sensory symptoms. Peripheral nerve mononeuritis multiplex is not often painful, but can be, and is associated with motor and sensory abnormalities in a peripheral nerve distribution, maybe involving 2 or 3 nerves, which makes it fairly easy to diagnose, and it's due to maybe vasculitis or something like that involving isolated peripheral nerves and giving that sort of a pattern or picture. Root pain is a lot more common in our experience, and it comes from disc disease, herpes zoster, and maybe Lyme as well is another cause for the severe neuro pain. So you see the roots coming out in relation to the discs, and so prolapse of a disc, bulging of a disc, or in later life osteophyte formation around these exiting foramina can pinch the nerve and cause lower limb pain, usually with paresthesia and of a root distribution. You can also get similar nerve entrapment with associated pain distal to the site in a claudication type picture with spinal stenosis, where you get claudication of the cauda equina, and that's due to hypertrophy of the ligaments, hypertrophy of the bone in an already narrow canal. Glove and stocking, neuropathy, often associated with type 2 diabetes. The patients can call their sensation pain, and it's usually of a burning quality. Sometimes it goes on to anesthesia or paresthesia, and again, it's usually quite easy to sort out if you get a good history. Autonomic pain, which is what we're dealing with now, is there are a number of terms for it: reflex sympathetic dystrophy syndrome, causalgia, complex regional pain syndrome, algodystrophy, and sympathetically mediated pain. So these are all slightly overlapping syndromes that have pain and autonomic features in common, and some of them have preceding injuries, and some have closed, and some have open injuries, etc. That doesn't define any of them. The autonomic features are allodynia, which is non-noxious stimulus causing a noxious experience, swelling, which is usually a global type swelling, temperature change, and it's usually cooling, though early on there may be increased local heat, but it's usually cooling, maybe 1 or 2 degrees temperature difference, color change, and it's often a dusky bluish cyanosis, and that relates not to poor arterial circulation but to wide open dermal capillary beds causing just cyanosis because of poor sluggish circulation. There's trophic changes possibly related to that, and related to the fact that you've got autonomic input into a lot of tissues, and so you get loss of hair, thickening of the skin, whitening or dystrophy in the nails, some muscle wasting, and osteoporosis. And then there's excessive sweating in the limb or part of it. So this lady, having had all this pain, I came out of it with associated autonomic features, had physio and occupational therapy, and that resulted. So she had neuropathic pain, she had a sympathetic block, and intensive therapy with benefit. Okay, so Mrs. Fellensood issues proceedings against the supermarket. Her physical signs have resolved with her therapy. She's got good function, but she's persisting pain. She's waking at night because of pain, and she has pain extending up her arm now, above the hand and above the wrist, and she's really quite distressed. So she goes to law. Her doctor and her family and her lawyer all agree that she has suffered a great deal and she needs to be compensated by the supermarket. But the supermarket, on the other hand, say, well, their orthopedic surgeon says she's fallen and she's had a fracture, and she should have maybe 5-6 weeks of pain, and then it should be resolved, and so all of this is inappropriate, and so she's now in this conflict situation, and this is the nature of litigation. A team of doctors and lawyers agreeing with her and believing her and being very sympathetic and empathetic to her, and another team who want to test how bad she is, and this is the system that we have constructed, and it's adversarial, and that does nothing for Mrs. Fellensood's head. The fact that there's people doubting her credibility and doubting her honesty, and others supporting her, so quite a conflicting situation. So we're then on to this other kind of pain where you can get many sites, you get associated visceral symptoms, associated sensory symptoms, fatigue, and sleep problems. So, and this is generalized or central pain. And I suppose the commonest pain in this group would be that of fibromyalgia, where we now know abnormalities within the brain on fMRI in these patients, so there is sort of an organic basis for it. They have pain associated with sensory phenomena and with somatic phenomena, and for this reason some people have labeled this type of pain as central sensory processing problem. And you can see therefore that the processing of sensation can be a problem, but it also can be a key to diagnosis. So usually there are many sites. In our patient, there's only her arm, but it's extending. So there can be many sites of pain, and these are the patients who sometimes come in and say it's all over. There's associated visceral symptoms. So there's bladder, there can be bladder dysfunction, interstitial cystitis, or recurring episodes of frequency with no apparent microbiology to say it's an infection. Bowel problems, particularly irritable bowel syndrome. Respiratory problems, and sometimes labeled as dysfunctional breathing, headache, sometimes described as migraine or recurring migraine or cluster headaches or some other loose term that gives an organic basis for headaches, or palpitations with normal ECG, normal cardiac investigations, normal 24-hour monitoring. So these patients can have these other visceral symptoms, sometimes contemporaneous with some of these somatic pains we're talking about, and sometimes prior to presentation with this type of pain or injury. They also get sensory symptoms, vertigo, sensitivity to noise, sensitivity to light. They complain of swelling, and they complain of experiencing swelling, but there's nothing apparent. So there is, again, the sensations coming from the periphery are altered, they're different. And allodynia, which I've described before. So all of these problems can occur, and they all reflect some way an abnormality within the patient's interpretation of their own sensations. Not only a malinterpretation or a different to what it used to be interpretation, but usually on the bad side as well. They also get fatigue and sleep problems, with poor sleep quality, waking during the night and feeling unrefreshed. They have poor response to conventional analgesia. So this lady has elements of central or generalized pain. It's not absolutely classical, but this is where it's going to, and this is where her psyche is contributing to this problem. Not her fault. And so this brings into bring me to tell you some thoughts about the pain experience and try and point you towards Dr. Melzak's theory of pain and neuromatrix in the brain, and how he describes the neuromatrix and the integration of pain into personality or into self. So there are many inputs into what is ourselves: our culture, personality, past experience, expectation, and anxiety, depression. And pain or noxious experience or any sensation is interpreted in this in this sort of light, or with those sort of inputs. And the sensory inputs are cutaneous sensory inputs, somatic input, visceral, visual, vestibular. So all our sense organs also input sensations, and they are processed in different ways by different people, and they're processed in a quite complex way, so that our personality, culture, expectation all influence how we interpret those and bring them to our consciousness. And they are, again, in a background of a hormone status, and a hormone status, it can be all sorts of things, and an immune status as well. So a hormone status at one extreme could be in the middle of a very aggressive football match, and the other in menopause or in hypothyroidism. So, and that all will change the way we experience those sensations. So there are neuromodules. So all of these inputs and their processing to give you the outputs go through a sensory, affective, and cognitive inputs and processing. So that what we know of pain tells us how to interpret what noxious stimuluses are coming in, how we feel in our mood, the same thing, and our sensitivity to pain. And it explains why two people might have the same accident, and one is back to work the next day and the other has a month off. So the pain perception then is on a background of cognitive, what we know about pain and what value we give to pain, positive or negative, or again our sensory, our sensitivity to the pain, and our affective input into pain, and how we feel about how we feel. And that then influences our social communications, our coping strategies. And of course the reverse is the case. So if you can influence the cognitive element of this. In other words, you tell the patient what's happening and why it's happening. You improve their way of thinking about their pain, and that should give them some comfort. Again, if you improve or you put different sensory inputs in, so instead of a patient resting all the time, for maybe inappropriately resting with a pain that is not improving with resting, then you need to try and help the patient to see that you'll cope better if we improve function and if we get other things happening, like exercise, like enjoyment of life, like going back to work. So in summary, the patient is the best witness. The pain is an indication of a lesion or a process. Not all pain is the same, and not all pain has been experienced by us. So we sometimes can't speak out our experience. History taking may be therapeutic and efficient. It should be comprehensive, and it will add to our efficiency, and it will add to how well we help the patient. So the checklist I'm going to give you is, I presume you have you have asked about the accident and that anything happened, but also ask about other sensory symptoms, other motor symptoms, visceral symptoms, sensation, fatigue and sleep problems, and mood, and the patient's understanding of what the pain is, and so that you can then correct any misunderstandings and at least start to improve pain and the patient's suffering experience before they even have analgesia. So thank you very much.